to how to prepare for the future pandemic. So I said, since public health learns from pandemics, this was a learning exercise. I have compared the public health. I started with chess. I am ending with cricket because both games have become popular. So lessons from cricket for future pandemics. Now there's a lot of talk of pandemics act. You should have a pandemic treaty and other things. But what I feel is that, like in chess, we should have a good position. We cannot play with one pieces. Similarly, in cricket, we should have a, say, if we take the example from cricket, to win a match in cricket, you should have a good field placement. And when you deal with health services and a future pandemic threat, we should have a good field placement. We should have the good placement of health centers and sub-centers all over the field, that is all over the country. Now we are having only close-in fielding. All the doctors and hospitals are in the urban area. Deep में नहीं है, तो boundaries वहाँ निकल रहे हैं हमारे. So presently health resources are inequitably distributed. And there is a great urban-rural difference and rich-poor difference also. Even in the urban areas, the poor do not have insurance, the poor do not have. So we should have a future pandemic. Even in this present pandemic, COVID-19 pandemic, the second wave, what happened? Because there were no available hospitals and health centers in rural areas, people crowded to the urban centers, and urban centers also panicked. And there was a lack of public health hospitals which could have adequate beds. So all the private hospitals, they have their own limitations. They are having too many specialists and super specialists who do not know how to handle normal infections and all. They only consent to their specialty. The science of medicine has got fragmented. The art has disappeared, because art means combining everything, like a chess player or like a good cricket captain. So we require a good field placement, and all the fielders should be in the sub-centers and equal number of fielders. Then make the cricket pitch should be reliable. You know, in cricket, the pitch matters. Good public health infrastructure, like the pitch is weak or any pandemic, any disease can become a pandemic. Daily we are losing 2,000 people from tuberculosis. We are losing 2,000 children due to malnutrition, because we do not have a good pitch. Even a normal ball, average bowler is taking wickets. We are losing children from malnutrition. So we should have a good pitch, means good public health infrastructure. Then pitch also means obese people are vulnerable, undernourished are vulnerable. If a disease strikes, if a pandemic strikes, so if the pitch is weak, we will lose a large number of people. So we should have a good control of population level obesity and comorbidities. For that, we require the public health services. Then we require more all-rounders instead of specialists, bowlers and batsmen. Now all doctors are becoming specialists and super specialists. So we require all-rounders who can treat the minor illnesses before they have to reach the specialist or before they have to reach the tertiary care center. We should have all-rounders at the primary health centers and the district hospitals who are the general physicians. Earlier we had general practitioners who could treat the minor infections before they become pandemics. So that all-rounder we require. Then we don't have to depend only on one bowler, that is vaccine or intervention. Like we are preparing that next pandemic, we have one side we have a new virus, other side we have a new vaccine, and there is a gap in between. So that is, we cannot depend on one bowler. Vaccine may be required as a judiciously to be used. You use your bowlers. A good cricket captain will use the bowlers very judiciously. He will not over bowl or under bowl. Similarly, we require and for that we require all-rounders who see the routine cases in the community riders rather than just virus at one end, microbiology or genomic surveillance and the vaccine. Both are high-tech adventures. They require a lot of technology, a lot of investment, but lot of in between simple measures can prevent lot of pandemics going out of hand. And then we have to take decisions based on local conditions. Like in Africa, in Asia, the pandemic had least impact, but we had the harshest measures in our country, which was not warranted, because in spite of that, 80-90% of our population got the infection. So we have to take decision. And when we did lockdown in all local conditions, we are already a very high dense country, crowded country. We increased the transmission. Whereas those people were vendors, they were working outside, the transmission minimum. So we blindly imitated the Western countries. So in future pandemics, we have to take a local decision, take decision on local conditions. So this is some of the lessons, as I said, because the latest trend in public health, we are having latest emerging diseases or imagined diseases. Sometimes we are having advanced technology, but we have to also think the latest trend in our public health policy. We have to take a latest trend in our public health policy, which is not very encouraging. The way things are going, we are not using the regional epidemiology, the regional decision making, like a good cricket coach or good captain should see the pitch in that year, then decide which bowler to require, which batsman to play. So we cannot take something what is happening in the county cricket in UK, what is happening in Australia, and the same pitch in India. Similarly with disease and public health responses, it should be just like a game of cricket, similarly, or a game of chess. Each chess is same pieces, same board, but each game is different. You cannot have the same rules for all. So this is I